For a discussion on orthopedic anatomy of the acromioclavicular joint as it relates to AC joint injuries. The clavicle is a key piece of the pectoral girdle, which helps connect our upper extremities to our central or axial skeleton. The clavicle helps suspend the scapula and shoulder to keep the joint mechanically aligned and functioning, by dispersing forces as well as placing the shoulder far enough away from the axial skeleton to provide unimpeded motion. The clavicle articulates towards the body's midline with the sternum at the sternoclavicular joint, or SC joint for short. More specifically, the clavicle attaches to the manubrium of the sternum and then courses laterally towards its articulation with the acromion of the scapula. At this SC joint, a cross-section of the clavicle is triangular in shape. This area is commonly referred to as the sternal or medial end of the clavicle. The middle two-thirds of the clavicle is called the body of the clavicle. It is slightly thinner or narrower than the sternal portion and is convex anteriorly. It transitions from a triangular form to a more round bone at the middle third. As the clavicle runs laterally, it becomes flattened or more broad. This area is known as the lateral clavicle or acromioclavicle. As stated, the bone at this end of the clavicle is more flat in nature at an average measurement of 9 mm by 19 mm. The bone then terminates at the acromioclavicular joint, or AC joint for short. The AC joint is a common area for injury. The trauma to the supporting ligaments, which we will discuss in a moment, cause instability and dislocation of the joint. This is commonly known as an AC joint or shoulder separation. The clavicle appears to raise superiorly as the rest of the shoulder sags due to its lack of support. The distal end of the clavicle, or the start of the AC joint, sits approximately 2 cm to 3 cm medially from the lateral border of the acromion. The clavicle is home for 5 separate muscular attachments. Anterior and inferior, both the deltoid and pectoralis major attach to the clavicle at separate sites. The deltoid's origin on the clavicle is anterior-inferior and spans the lateral 1/3 of the clavicle. The origin also spans the AC joint and wraps around the anterolateral and posterior acromion. The pectoralis major origin is at the anterior and inferior aspect of the clavicle as well, but attached more medial across the medial 2/3 of the clavicle. It then fans distally to attach to the sternum and even has fibrous connection to the abdominal musculature. The separation between these two muscles leaves an open interval called the deltopectoral interval, or deltopectoral triangle. This area is further demarcated by the cephalic vein. This is a common site for surgical dissection during an open anterior shoulder procedure. Another muscle with an insertion on the clavicle is the trapezius. Posteriorly and laterally located, the insertion of the trapezius muscle extends from the acromion across the AC joint to its clavicular insertion on the lateral third of the bone. At an almost opposite position, the sternocleidomastoid muscle attaches slightly more superiorly on the sternal aspect of the bone. The subclavius muscle attaches to the inferior side of the clavicle in the middle third of the bone. There is a subclavian groove centered in the middle of the undersurface of the clavicle where the muscle resides. This muscle helps to suspend the first rib by linking it to the clavicle. There are a number of ligaments that help connect the clavicle to the surrounding girdle and other structures. The most lateral of these ligaments is the acromioclavicular ligament. Also called the AC ligament for short, this ligament works in conjunction with the joint's capsule to provide multi-directional stability to that joint. This ligament encapsulates the entire AC joint with 4 separate bands named for their location around the joint. It has anterior, posterior, inferior, and superior bands. The posterior and superior bands are the thickest and the strongest. Together they all help reinforce the AC joint capsule. The coracoclavicular ligament is divided into two separate ligaments. The trapezoid ligament attaches to the clavicle's undersurface on the trapezoid ridge, 2.5 centimeters medial to the AC joint on average. The conoid ligament, which is the other half of the CC ligaments, attaches even more medial to the trapezoid, at about 4.5 centimeters from the AC joint on the conoid tubercle. These measurements are important during an AC joint reconstruction procedure after an AC separation injury. Protecting and stabilizing the sternoclavicular joint are anterior and posterior fan-shaped bands of the sternoclavicular ligament. This bridges from the medial end of the clavicle to the manubrium of the sternum. There's also a ligament band called the interclavicular ligament that runs between the two SC joints. It sits atop the manubrium of the sternum at the superior aspect of the sternoclavicular ligaments and connects the superior aspect of the medial clavicles or SC joints. Much more medially lies the costoclavicular ligament. This cone-shaped, strong ligament runs from the most medial aspect of the first rib to the costal tuberosity of the clavicle. It sits just lateral to the sternoclavicular joint. There are many small vessels that live around the clavicle, but there are few major blood vessels and nerves that reside close enough to the clavicle and are pertinent in clavicle fracture and shoulder separation injuries. The brachiocephalic trunk off the aorta gives rise to the large subclavian artery. This artery resides in the neck area and runs laterally over the first rib. As this artery crosses the lateral border of the first rib, it turns into the axillary artery and courses anterolateral down the arm. Running parallel to the artery is the subclavian vein. It runs in the same direction as its arterial counterpart. It becomes the axillary vein and from there gives rise to the cephalic vein at the level of the deltopectoral interval. These structures are important to note in the setting of a clavicle fracture or injury. Because of their possible proximity to the injury, there have been case reports of vascular injury at the time of fracture or during the surgical repair. Studies using CT scan to assess the proximity of these vessels to the fracture have shown that the vein can be as close as 1 millimeter from the clavicle at the middle third, and the artery can sit around 4 millimeters to 5 millimeters from the clavicle. This distance can change with arm position, as well as the type and location of the fracture. The vessels actually sit closer to the clavicle prior to fracture, and the spatial relationship grows after fracture, but the risk of injury is still always present. There are obviously many nerves in the vicinity of the clavicle. Regarding clavicle fracture and AC joint reconstruction, the main nerves that come off the brachial plexus, unlike the adjacent vessels, are typically not at risk. There have been cases of brachial plexus injury, typically due to the sequela of the injury, but injury to the nerves due to the trauma is an exception. At its closest point to the clavicle, the brachial plexus is approximately 12 millimeters from the bone. This point is just over half the length of the clavicle away from the sternoclavicular joint. The supraclavicular nerves arise from the third and fourth cranial nerves. They are responsible for sensory innervation of the skin surrounding the clavicle. There are 3 separate branches that supply the lateral, middle, and medial portions of the shoulder and thorax around the clavicle. You can see that the nerves typically sit anterior and posterior to the clavicle at the lateral aspect of the bone. At the middle third of the bone, there is some crossover. An incision across the AC joint along the lateral portion of the body of the clavicle can be made without nerve involvement. As the incision or injury is more medial, injury to these sensory nerves becomes more likely. There are safe zones that extend approximately 3 centimeters from the AC joint and 2 centimeters from the SC joint. Other than that, surgeons would have to perform meticulous dissection during their approach in order to avoid any nerve injury. The geometry of the union of the clavicle and acromion leaves a free space just medial and posterior to the AC joint in which we can make a portal for arthroscopic instrumentation. This specialty portal is known as the Navisor portal, which is named after the surgeon who popularized it. It can also be known as the superior or supraspinatus portal. This anatomic landmark sits superior and medial to the rim of the glenoid, making it ideal for anchor placement during arthroscopic glenoid procedures.